Right, so I will be walking through the background of the Medicare reference-based price report before handing it over to Miga to demonstrate the public report. For several years, CIVHC has been collaborating with the RAND Corporation to create Medicare equivalents of commercial claims in order to gain an idea of both the differences between commercial and Medicare payments, but also to benchmark Colorado commercial rates to other states using a common measure or metric across states. The CIVHC report that we're going to be looking at later features information about the Division of Insurance and county level Medicare reference-based pricing costs by mapping, and then also looks at the patient experience using the CMS 5-star rating so that we can get an idea of both cost and quality in one snapshot. It also includes trend information from 2017 to 2018, so we can see how things are moving, and then infographics both at the DOI and the hospital level. Some of the key findings from this year's most recent information is that our outpatient service payments are significantly higher than the national average. National average is about 267% of Medicare, so just over 200% of Medicare. And in Colorado, it's over 300% of Medicare for our outpatient services. This really pinpoints outpatient services as one of the biggest cost drivers for healthcare services in the state and places Colorado outpatient services in the most expensive on average across the country. We also found that hospital prices are varying widely across geographies. Two of the lowest paid hospitals and two of the highest paid hospitals are all located in rural counties. So we're seeing less similarity within rural or urban areas. From 2017 to 2018, the payments in all but one region of the 9 DOI regions in Colorado decreased. Nationally, however, only 2 of those regions are still underneath the national average or the national benchmark, meaning that Colorado overall is still one of the most expensive places in the country to be receiving care. Of the 52 hospitals that had both 2017 to 2018 data available for trend measuring, the majority had a reduction in commercial payments in 2018 compared to 2017. But we did have 11 hospitals that increased their rates over 2017 rates. Here you can take a look at the variation across hospitals in Colorado. They vary from 124% of Medicare to over 500% of Medicare on average. And you can see the distribution here. This is obviously too small to be able to read in detail, but this is available on the website. You can see right here, this blue line, the first blue line is the national average. And then the second blue line, the lower blue line, is the Colorado average. And so you'll note that the majority of the hospitals in Colorado are above that national reimbursement average. And here we can see the trends from the Division of Insurance, looking at the variation from year over year, and then also looking at current distribution. So you'll notice that the West region went up by 2.5% from 2017 to 2018, and that the vast majority of our DOI regions are significantly above the national average of 247% reimbursement. So how are employers using reference-based data? So this is a common metric, as I mentioned, across states. So we have a lot of examples from other states about how these can be used to really improve benefits and improve contracting for employers. So the California Public Employees Retirement System used the reference-based information to set a benefit threshold level of $30,000 and saved almost $3 million in just their first year. Montana is using reference-based pricing to set their contracts and to set their payment limits so that they have a maximum of 230% of Medicare as a hospital payment. And then this can also be used for reference-based pricing, not just an overall contract, so that individual vendors could contract with individual employers, can contract with a vendor to reprice claims and pay a set percent of Medicare across the board. So I'm now going to switch over to the live report and let Migo walk you through how that report works and what's available on our website. Miga?
Good afternoon, everyone. Thank you, Kristen, for the introduction. So this is an interactive dashboard, like Kristen mentioned, and it is on our website. So you can go to civic.org and look for this. So we have two tabs here where we are showing overview data and then the trends data between 2017 and 18. In the overview tab, you can see there are three sections. The first one is showing the filters, which you can select by which region you want to see, like county or DOI. You can select DOI and the map would change on itself and it would make interactive as well. Second is the service type, like it was mentioned, we have three different service types: inpatient services, outpatient services, and combined inpatient and outpatient. And the third portion is showing the reference of low to high in the color coding. In the map region, it is interactive. If you can hover over it, you would see a tooltip where you can see which DOI or county it is and what percentage changes are there. You select any one of the county, and the portion of the third portion of the analysis below changes itself. The hospital names changes which are available in the RAND data for that county or DOI region you have selected. Once you select over the map again, it will revert back to the home dashboard. And the third portion on the down is the analysis of all the hospitals in Colorado. We are showing three different numbering. Can you cancel it? Yeah, thank you, Kristen. If you go down, yes, you can see there is analysis. We have mentioned 5 or 6 different parameters for each hospital based on percentages of Medicare by hospital, by DOI, and by county. We have also included patient experience and hospital overall rating from the CMS data. Here you can select each of the hospital and it would show in map which DOI region is the hospital representing. And if you click back again on the hospital name, it would revert back the map. Click on the region again, Kristen. Thank you. The second tab, which we have, it's about the trend since RAND is producing these results for last few years, and we are showing results based on 2017 and 18. Not all hospitals are available in both the data. That's why you would see many hospitals with null data. And that's why the trend analysis won't show any data accordingly. Here also we have two sections. First one is the filter where we are letting people choose between DOI and county. Second one is within DOI or county, which region do you want to select? Third is the service type like the previous dashboard. And last is if you want to see the ascending and descending order of any one of the columns, you can select that and it would change automatically. And you might see, like in 2017, one hospital has highest percentages, but it may not be in 2018. And you can select even the percentage change and see which hospital is faring well between these two data points. So if you have any questions, reach out to me. And this is as interactive as you can. Select, you can, this is right now selected based on alphabetical order by hospital name, but by sort by, you can change it whichever descending order you want to see them as. Any questions, please let me know.
Thank you, Miga. And we'll be answering questions in the chat box. And if you have any more detailed questions, you can feel free to reach out to Miga here at Civic. I'm now going to hand the presentation over to Dave Dale and Emma Anderson. We're going to walk through some of the reports that we have available to support employers in their work for better prices and stronger negotiating. Dave?
Hello, everyone. My name is David Dale. And if you could go to the next slide, Kristen. Civic began to work with the leadership from the Colorado Business Group on Health and the Peak Health Alliance leadership and others, employers in particular, to develop several standard reports to help inform the employer community around improving quality and lowering costs. To date, we have 7 reports that have been developed, one of which is the reference-based price report, which Miga just provided a brief overview to. Additionally, there's the low-value care, potentially avoidable ED visits, and top 5 procedure cost savings. Emma is going to walk through 4 of these in a moment, the bottom 4, and we'll give a snapshot of what those reports look like. But it was a very collaborative effort working with the leadership of the purchasing alliances and employers over the past several years to develop the framework for these reports. Next slide. At the present time, all of these reports are available at no cost to employers or employer groups who have sufficient claims volume in the Colorado APCD. We are able to provide reports. We do follow the CMS data suppression policy. So for smaller groups where the claims volume and the counts begin to appear where they are actually less than 11, we are not able to produce reports with claims volumes at that level. But where there is sufficient claims volume for employers or employer groups, we are able to develop these reports, again, at no cost. We are providing them and very much encouraging and asking for feedback on how these reports are useful. What could we do to improve upon them? And if you do have an interest in exploring whether we're able to provide a report for your group, you can reach out to me. My email address is here. The process is pretty straightforward. We can turn them around quite quickly. We will do a demo of the reports for you, and again, set up a feedback loop call because we're very much interested in identifying every opportunity we can to make these actionable and user-friendly for the employers. Next slide. Before we get into the demo, I would like to also share an example of the other analytic capabilities that exist at CIVHC. This was a report that was requested by the Colorado Purchasing Alliance, one of the purchasing alliances, and it was a case study looking at potential cost savings available for outpatient procedures, comparing the cost of those services at hospital-based facilities versus independent freestanding centers that were not owned by a hospital or a health system. That was the ask for this particular report. And we looked at this across 10 outpatient surgical procedure categories for 2018 and 2019. You can see those categories in the orange boxes, and then the average savings for those services being performed at a hospital-based outpatient center versus an independent freestanding center. The average savings across the 10 categories was 44%. In the bottom of the screen, we do show a potential cost savings for this time period. And on the left-hand side, you see there, if there was a shift of 10% of the volume for this population that we looked at from the one setting to the freestanding independent setting, a 10% shift in volume would result in a $1 million savings, whereas a 50% shift would result in a $5.7 million savings based on the analysis that we did. So this is an example of the type of analytics that we at CIVHC are able to do with working with data requesters. And what I'm going to do now is hand this off to Emma and have her give you an overview of 4 of the actual employer reports that we have developed. Emma?
Thanks, Dave. Hi, everyone. I'm Emma Anderson. I'm a reporting analyst at CIVHC that's been working on these reports for the last year and a half, almost 2 years. I will say, unfortunately, we don't have time during this webinar to go into the live reports, but there's a lot of interactivity built into each one, the ability for the user to drill down and see exactly what they want to see in this data. So if you're at all interested, I really do encourage you to reach out so we can set up some demos and you can see these reports in action, because you can get a lot more insights than the high level points that I'm just going to point out today. The other thing I want you to know about all of these reports, with the exception of the prescription drug report, is you get to see your data and compare it to a county of your choosing, a division of insurance region of your choosing, and statewide benchmarks, the same way that the reference-based price report that you just saw did. So this first report is the top 5 procedures cost-saving analysis. So we're actually able to identify the entire cost of a procedural episode. And what that means is we're looking at costs from before the procedure, such as possibly diagnostic imaging, any labs that need to be run before the procedure, the cost of the procedure itself, and any aftercare or post-procedure services that occur. So rehab, physical therapy, medications, as well as any complications that occur during the episode. So by being able to group all these costs, we're able to see what something like a knee replacement looks like from the very beginning of the process through all the aftercare and post-procedure. It's a much more accurate reflection of what that knee revision is actually costing than just looking at what that procedure costs. So with this report, you can identify amongst your employee population what are the types of procedures that are driving the high costs. You can examine the costs by each of those phases that I've been talking about, the procedure itself and post-procedure, and see how those costs are varying based on the setting, whether it's inpatient, outpatient, professional. You can compare the average costs of post-procedure services. So we broke down that post-procedure phase into the different physical therapy, medication, rehab, even ER visits and complications, and on average, what is being spent on each of those. As I've mentioned, you can see the complication rates at both the procedure phase and post-procedure phase. And then the final portion of this report does compare for each type of procedure, what is being cost on average when a member goes to a specific facility. So then you get to kind of cost compare between different facilities your population is going to. Cost here would be total charges. So it's not just what the patient is incurring. It's also what the providers are covering as well. I will say the facility comparison, while very useful, that is subject to a lot of suppression. As Dave mentioned, anywhere where less than 11 procedures have been performed, we do have to suppress. But we hope as we add more and more years to this data, that becomes less of an issue. Next slide. Okay, our chronic conditions and avoidable complications report. So we are able to look at members that have these chronic conditions and identify of those members, how many just have one condition and how many are suffering from comorbidities. So perhaps they have 2 or 3 or more conditions, somebody who has diabetes, as well as hypertension. So by breaking down your population this way, you're able to identify not only what chronic conditions are driving high costs among your population, but also the specific member population in terms of comorbidities, how that is driving cost and those differences between those member populations. Then you can also see, based on the type of chronic condition and that comorbidity population, the complication rates and ER rates and costs associated with those. And then we break it down even further so that you can see, based on the chronic condition, what are the top services that those members are incurring. And when they do need to go to the ER, what are those top diagnoses that are driving them to the ER, and thus a lot of those high costs. And then again, I'll reiterate, as you can see on the screenshot here, you always get to compare your own data to counties, DOI region, and statewide. So you can really see where your data or your population is very different from some of these geographic benchmarks. Next slide, please. Okay, prescription drugs and generic alternatives. So this is broken down into 3 different dashboards. The first one you're seeing here, a very high level overview. What are you spending on pharmaceuticals, and how does that break down for specialty drugs versus brand versus generic drugs? The rest of the report will show you amongst your employee population, the top 25 drugs that were prescribed, both in terms of spending and in terms of volume. And then of those top drugs amongst your population, which ones have generic alternatives? And it will give you the details, name and dosage, strength, all those details of what those generic alternatives would be. And that's really where the cost savings is going to be. Where can you possibly swap out a higher cost drug for a generic alternative? So this report is probably one of the most, probably one of the most immediately action oriented and useful in terms of what you can use to lower some of these pharmaceutical costs. Okay, next one. And our cost driver analysis. This report is, I think, the best for just giving you an overall picture of what your healthcare spending looks like amongst your employee population. So at a very high level, you can see of all your costs, what percentage was incurred by inpatient services, outpatient, professional, or pharmaceutical spending. So you can see that breakdown, and you can see how that changes over time. And we try to give you both total spending and per member per month spending, so you're not comparing apples to oranges. And then on the second half of this report, you can drill down into one type of spending category, let's say outpatient, and it will give you a list of all the most expensive services within that spending category. So for outpatient example, you can see how much you're spending on surgery, how much you're spending on ER rates. And then you can really drill down to the types of services that are driving costs within these spending categories. Next slide.
Thank you,
Okay,
Emma.
so that's all I have. I know it was very quick. I just encourage you guys to reach out. We are also very happy to do demos and discuss these in more details. There was even more reports we've developed that we didn't have time to show today. So if there's any interest, please contact us, please contact Dave. No wrong door. We're very happy to talk to you guys.
Great. Thank you so much, Emma.